want to acknowledge the land itself that we are on. We want to acknowledge that this land was not ceded, this land was taken. We want to acknowledge that we are doing this work on land that was taken, and then our work is an acknowledgement of that. We acknowledge all of you, the lands that you were from, and your ancestors. So welcome. I'm Andrea Henderson. I am the clinical department director. I get to oversee all kinds of fun people, high clinical interns. I oversee the outpatient program here at CSS, and that's a program that provides free and sliding scale grief therapy. We do work with seniors in their homes. We provide free therapy to people 65 and over who need services, mental health services. We also provide work with school-based programs, and we provide a lot of bereavement groups and a connection group for older adults called Building Connections that's virtual. And we have a provider loss group. So I co-facilitate a group with Danielle Geary for mental health providers, that's case managers, therapists, psychiatrists, social workers who have lost a client to death. So that is the work that we do here at CSS. And pretty soon we'll be launching our organizing and responding to youth in crisis, the ORCA program, that's going to be managed capably by Sarah Kim. And I'll pass it over to Jess, and she can introduce herself.
Hi, everybody. Thank you so much for being here. I know time is really valuable, so I always appreciate when folks show up. So thank you so much. I'm Jessica Wolfinger, and I am the Director of Crisis Services for CSS. And I oversee the 911 and our local crisis line, the text line, and our follow-up program. And my experience, I've been practicing social work since 2001 and have worked in hospitals and in crisis all of that time. And I saw an AFS person here. I'm currently an on-call clinician for the care team, which is the mobile crisis team in the city of Alameda. So good to see Ashley here. So that's me.
We do a lot.
We do a lot.
we're not trying to make ourselves sound amazing, but we were just like, just acknowledge it. We do a lot. I also wanted to say, if you click on the top, if you click speaker view, that will only show you Jess and I. You can also choose to hide non-video participants to get kind of a panel version. If people want to turn off their cameras, then if people select to hide non-video participants, then they can just see Jessica and myself. Just giving you guys some options. And Jessica and I are presenting today on collaborative approaches to managing suicide risk, but more importantly, and in the spirit of collaboration, we would love to hear from you all. So we do have slides, we will go over them. Jess and I love talking about this, and we can go on and on forever. But please interrupt us, ask questions, really feel comfortable to please use this time in a way that's gonna address what your questions are. And if for some reason we don't get to your questions, we want to know your questions. That's going to really help us think about other future trainings. So we want this to be as engaged and participatory as possible. Also wanted to say I'm wearing this Outlandish t-shirt. It's Planter Day Outlandish t-shirt. I'm not just dressed casually for fun. This is a t-shirt that benefits crisis support. So Planter Day is a local plant shop run by someone named Matt Day and his partner Yumi. And they, on their own, initiated supporting crisis support and suicide prevention in Alameda County. They're big proponents of suicide prevention. And so they partnered with Outlandish to make a t-shirt. And so it's a t-shirt. This is what a drawing of the inside of the store. But the proceeds actually benefit us, which is really, really lovely. So I want to put that out there. And I'm going to go ahead and share my screen. Also see in the chat, people are just wanting to know more about collaborative approaches, and someone wants to know about working collaboratively with youth. We do have some slides on that, but again, please just drop in. What do you want to know? What are you curious about? Okay, so we already did this intro. And then here's the agenda. So first we're going to talk about why talk about suicide. Then what is the collaborative approach, legal ethical considerations, cultural factors, the crisis continuum, and resources in Alameda County. Again, please jump in at any time. All right, Jessica.
Great. So why talk about suicide? In 2007, there was a study done that estimated that 50 to 70% of mental health professionals have experienced at least one patient suicide. Most clinicians, they report being anxious. And, you know, when the word even suicide is mentioned, people get really nervous. Clinicians get very nervous. And they often, and one of the things, and I hear this, and I've heard this throughout like the 20 plus years that I've been sort of in the mental health world, is if a client says the word suicide or admits to having chronic suicidal ideation, they will often sort of break with the client. It's that scary for people. And so part of this presentation is to help you sort of maybe allay some of those fears that you might have. Also, when a therapist becomes too anxious or nervous or fearful in regards to liability, what that does is it is really harmful to the client, because that person then is stuck in the middle of a suicidal crisis and has to seek another therapist. And that's not good for, just spoiler alert, not good for people who are suicidal. So our hope is that we increase quality care and for you to know that suicidal risk can be managed. So these questions are, what comes to you when someone tells you that they're suicidal? If a client tells you that they're suicidal, what are some feelings that come up? I can't read the chat, so I don't know.
Fear, worry.
I think I can read it, and I think Sarah can read it too, if needed.
Okay.
Yeah, Amanda says it can feel high stakes. Simona says their pain is overwhelming and they want out.
So, you know, people, if someone tells you that they're suicidal, it's normal to feel overwhelmed. It's normal to feel like you don't know what the next thing to do. The words sort of stop coming. So how do you all prepare yourself? Because it's inevitable that most people that work in the mental health field are going to eventually work with somebody who is in suicidal crisis. So I'm wondering what you all do just now to prepare yourself for working with those folks.
Hi, this is Stephanie. I'll go since we deal with this on a regular basis. We do a series of training, some of which through CSS. We talk openly about it on a daily basis here. We ask the question, just because we are operating crisis services and mobile crisis teams. So, you know, when we train our interns, we are saying to them, you're going to have to ask people, are they contemplating suicide, killing themselves, hurting themselves, and asking in a variety of ways based on culture, age, you know, level of intellectual ability, because sometimes, you know, we skirt around the question. But we talk about it every day almost here. So there's a lot of training, there's some real-time consultation, there is debriefing around, you know, when someone tells you or you experience, you know, a young child who's saying they're suicidal, which is really, I've experienced that and really impacted me. So debriefing, support, training, that's what we're doing to prepare folks. Just having the real conversations about, you know, being in that space with people.
Yeah. I think that's exactly it. So that it's not a surprise when it comes up and you don't know what to do at all, is to prepare by training, by discussing suicide openly. And I always want to say this because this is a common misconception, that if you ask someone directly, do you feel like killing yourself? That does not increase suicidal thoughts. It's been shown over and over again. So the more comfortable you get with asking questions that might seemingly be uncomfortable, and the more familiar you are with practicing a sort of therapeutic muscle, so to speak, the better this will go with folks. Thank you, Stephanie.
There's a couple of other chats. So Karen says, remember, and it's a good thing to hear someone trusts you. And Diana says, I consult with my supervisor and attend to various trainings. Debriefing definitely helps. Appreciates your sharing.
Yeah, thank you. Thank you so much. Thanks for that thought, Karen. I think sometimes we forget to realize it's an honor to have someone come to us and tell them that they're thinking about ending their life. I appreciate you putting that out there. Okay, so what is a collaborative approach? A collaborative approach is defined as viewing your client as a full partner in the decision-making process. And treatments that work tend to be easy to understand, grounded in theory, and focus on treating patients as partners. That's from an article called New Research in Suicide Prevention. And as we heard earlier with Sarah's panel, there is evidence-based intervention called CAMS. And one of the bases of CAMS is that it is collaborative. So it's not a clinician coming to a client and telling them the best thing to do. It's a clinician coming to a client and asking them, what skills do they already have? What are the resources that are available to them? What are their thoughts on what's the next direction? Collaborative approaches increase the therapeutic alliance, which is a protective factor in managing suicide risk. We also believe that it is only our clients who know what's best for them. Our responsibility as clinicians is knowing the resources and our ethical and legal guidelines. So I'm just going to stop for a second. What do you all think about that? What do you all think about taking a collaborative approach and managing suicide risk? What comes up for you as maybe some reasons why it could be helpful or concerns you might have about taking a collaborative approach?
Anna
Yeah.
says it gives agency and choice to the client.
Yes. Any other thoughts? Does this seem like, I see something in the chat. I think it is necessary and a primary focus. Yes. Do people think this is the common approach, that it's how it's done most often when people are feeling suicidal? Stephanie says it's the only way to go, which I appreciate. There's no other options, according to Stephanie. But is this what we see? Is this sort of the way suicide is handled most often? Unfortunately, no. Yeah. It's not going to be effective if they don't agree, feel they can do it, or have buy-in. And then it sounds like we have here someone saying that the second statement about clinician's responsibilities is very limited in its scope. Nancy, do you want to say more about that?
Yeah, let's see. There's nothing about connecting, caring, alliance, the feeling between the client and the clinician. Yeah, there's so much more than just knowing the resources and the guidelines. And
That's very true.
I think if a clinician is just focused on those things, that's when they get scared because they're thinking legally and in terms of covering their bases rather than connecting with the person.
Yeah, I appreciate you saying that, right? I mean, a clinician does way more than just know the legal ethical guidelines. They do all of this connecting and all of this relational work that really is the intervention. So thank you for naming that. I think we'll talk a little bit about what a clinician's ethical and legal guidelines is. And I think as we might have said in the beginning, our hope, Jessica and mine's hope, is that once people are really clear on their guidelines, it reduces some of the anxiety and allows them to be relational. But let's see if that comes through in this training. And so, yeah, well, the reason why we're being really clear on what it means to be collaborative is because just in my experience, I've seen once risk goes up, clinicians and providers tend to be much more rigid and a little bit more fearful and sort of start to be a little bit more patronizing and assume more of a paternalistic approach and assume that they know what's right for that person. I think that's maybe kind of like a commonly accepted way of being in our society, that if someone's acting in a way that doesn't line up with our view of logic, then we as the logical, responsible party have to step in and make decisions for people. And unfortunately, we see how that can play out, right? And what that feels like for clients. All right. So let's talk a little bit about our legal and ethical responsibilities. And I'm curious if, as we talk about it, if any of this seems surprising or new, or if people already know this. Go ahead, Jess. You're muted. You gotta unmute yourself.
Thanks. So, having done this for a long time, I just wanted to add that when I first started, really clients who were called patients at the time had no sort of, if you said you were suicidal, you were going to the hospital, and like it or not. And in those 20 years, there has been a significant and palpable shift, right? Where now, because we knew then that forcing someone to go to the hospital, even when it wasn't necessary, but it was the liability was driving that, was really destructive. And in fact, we know if we're talking about the highest level of intervention hospitals, they're not really places where people heal. They're great places. And I worked in hospitals for a long time, no shade on hospitals, but they're really not designed for therapeutic interventions. It's primarily a medical intervention. Where someone goes, they're in a locked unit, and they are given medicine. And so not having some of the other continuum of care that we now have, at one point 20 years ago, that was where you went. You said you were suicidal, you met with a therapist, you were going to the hospital in most cases. And that was driven by the change has been driven by a shift that is more collaborative. And I will say that collaborative work is harder. I think it requires more from us than just saying, okay, I'm signing a 5150, you're going. But it's so worth it. So, all right, on with legal and ethical responsibilities. All right. When a therapist is aware their client is at risk of dying by suicides, courts have generally held that the therapist has a duty to take reasonable or appropriate steps to prevent the client's suicide. So, what are reasonable and appropriate steps? Many in the therapeutic community, if you're a mandated reporter, you know that if you hear about child abuse or elder abuse, you are mandated to make a report, or if there's, to the ombudsman, whoever. And the reason I bring this up is because there is no mandate for us to hospitalize a client if they're suicidal. And, it's really important to keep that in mind. So what's reasonable and appropriate is very broad, right? So really, what are we required to do? All right, here it is. Here's the requirement. This is behind the curtain, looking behind the curtain in terms of your liability. A court defines this as what would be expected of a therapist who is exercising the reasonable degree of skill, knowledge, and care that would ordinarily be exercised by other therapists when practicing under similar circumstances. So basically, I mean, I guess we could stop and say, like, what do you think of this? This is the court standard. You got to do what any other clinician with your specific licensure would do. That's reasonable. I just wonder what your reactions are to this being it. Yep, vague but flexible. Broadness. This broadness could be a double-edged sword. Dr. Ashley, would you talk about how it might be a double-edged sword if you're comfortable?
Yeah, I'm fine with that. Like how it's written is very clear. Like if you should have the skills and the knowledge and the degree and the capability to know exactly what to do or know what you should be doing, and other clinicians that are educated and supposed to, like, trained in these things as we are, to respond to someone who is suicidal, which is great. However, I also think that leads, which the broadness is helpful because that means we can treat clients how we view should be, you know, whatever approach would be most helpful to them, which is good, I think, if you're thinking the collaborative approach. The downside would be that not everyone thinks that way. And so that could miss a lot of, not having clear instructions could miss a lot of things. And so people who might not have that training and are also working with these groups of people would not have the information needed to treat them appropriately, I guess, is all the things I want to say.
Yeah. Yeah, it's a really good point. It's so broad, and in it, you know, if a therapist is sitting here, a clinician is sitting here and knows nothing about suicide or what is reasonable, this broadness can result in all kinds of problems. And yet for folks who do know and are familiar and take trainings like this, you will know what's reasonable. That's the hope. And you just have to do that. But it is incredibly broad. Yeah, thank you for that, Dr. Ashley. Okay. So what is reasonable? So let's take the broadness out of it and talk about really the things that you need to focus on, which are: one, assessing for suicide on intake by using a standardized screening tool. The Columbia is one that is often used, but really, whether you use the Columbia, which is a standardized screening tool, or you use a tool that you develop, that it must cover certain factors. And so those factors are: do they have suicidal ideation? Do they have intent? Do they have the means? And do they have a plan? Any screening tool should include those things. And then the second is identifying risk factors and creating a safety plan regarding risk factors. So if you're interacting with someone who really has ideation, has thought about a plan, but there's no imminent action being planned, part of being responsible is working with collaboratively, there's that word again, to develop a safety plan and really get at what are the risk factors that are driving that. And normally when you're dealing with suicide, it has to do almost inevitably with loss. So a divorce, financial impacts, things like that. I mean, there are more factors than this, but when I'm talking to people and I'm looking at risk factors, I'm going to be looking for loss most of the time. And the third thing is you have to explore means, safety means. So that means distraction, like does watching television help? What have they done in the past to keep safe? Who is their support system? All of these things should be done. I'm trying to read. I believe every situation and client is different. None of us believe would even make any decisions without knowing all the facts to the specific case. Yeah, absolutely. Okay. So in terms of note writing, anytime you're dealing with someone who has suicidal ideation or you feel is at risk, it really is important that you document it. And as someone who struggles sometimes to get my notes in right away, if you're dealing with someone who is suicidal, get the note in that day. Because if something happens between now and the time you write the note, it could be problematic. So you have to document each session. A second thing to do is increase your sessions, individual group. If you're seeing someone in individual therapy and they're talking and they have suicidal ideation, see them twice a week or refer them to a group. More support, the better. Referring a referral to a psychiatrist if the client is willing to do so. And then communicating with client support team. So, you know, at one point I was working at Sausal Creek, and one of the great things, it was this very small clinic. So when a client presented as suicidal, you could have a conversation with their psychiatrist. You could have a conversation with a case manager. And so that everybody was on the same page. And I think that's very rare these days, which is really sad. But I think that helps a lot inoculate the risk and provide the best treatment. Okay, next slide. The other piece of it is coordinating care with risk factors. If someone is unhoused, if there's substance use, if family conflicts are there, who can you refer this person to help mitigate this risk factor? Provide information on crisis referrals and explore respite programs or hospitalizations. So we have a case example. Cameron, a 21-year-old college student, comes to therapy following the death of a friend. During the intake, they tell you that they often, I can't read. They often think about suicide and that the suicidal thoughts have been increasing. They tell you that their plan is to borrow a friend's car and drive off a cliff that they pass by daily on their way to school. Cameron also discloses regular alcohol use, which they say increases their sense of isolation and hopelessness. They report that the one thing that tethers them to life is school and being close to graduation. And they think that the suicidal thoughts could become unmanageable if they fail all classes. So I'm wondering if anyone would be brave enough to talk about what would be reasonable and appropriate for you to do if Cameron walked into your office. And we can go back to that slide so you can look at it. But what are some things a reasonable person in your position would do?
Well, the first thing I might do is thank them for talking about this with someone. because it likely wasn't easy for them to talk about this and their fears and the thoughts that they want to harm themselves. Like, that's a lot. And then I would want to assess more about, like, how likely is it that they're going to borrow a friend's car and drive off a cliff? Is that really likely or not as likely? It's more fantasy thing, or like, what are the actual risks here? Assessing that, and then safety planning, really, like thinking about how we can keep this person safe and whatever that looks like. Is that safety and us just continuing to talk about it? Will that keep you safe? Is that safety bringing other people in? Is that safety thinking about getting you those crisis supports and finding the nearest hospital? Having that discussion with them.
Definitely. I love that you're starting out by thanking them for being vulnerable with you. I think that's so important. Anybody else?
I have some notes in the chat that I can read.
Okay.
So we have ask about support system. We have succeeding in school as a protective factor, exploring whether Cameron has spoken to teachers and other supports at school about their situation to minimize the risk of failing and dropping out. We have who's the friend, exploring that relationship as a potential protective factor. These are all great ideas. Anything else come to mind for people?
Okay. Let's move on.
How would you build in collaboration?
Okay. What are some ways that you collaborate with the client? Some of them have been mentioned. Yes, working on a safety plan or RAP. Yes. Look for buffers. What are some other things that you might do? Some other stuff that were mentioned. What about looking for natural supports? How about therapeutic interventions? Would you maybe increase Cameron's sessions or get him involved in a group? Yeah, exploring their community. Okay.
I wonder about like just starting off by asking him how worried is he about this? Yeah. And as Stephanie said, what does he think is going to help? We have some really great ideas, but I wonder about just starting off with like first asking him to rate his suicidality, like his worry about it himself, and then asking him about some things that could be helpful and starting there. That is part of like a safety plan and a RAP plan. So I think people are all, that's kind of what you're mentioning, but I feel like so often we kind of jump to problem solving too, without stopping and seeing where is he. Yeah, Nancy says, explore what parts of him wants to stay alive. How has that been functioning lately? Why is that winning right now? Then talk about making this section longer and canceling a next appointment, good logistics to make sure you stabilize before leaving if possible.
Yeah. And I just want to point out, like, as a plug for the crisis continuum, how far we've come, because if 20 years ago that happened, that client would be going to the hospital, no questions asked. So that's my plug of how far we've come. Yeah. All right. This is really important. And so go slow. If you're hearing this from somebody, do not let the anxiety take over and the problem solving take over. It's really important that you take your time in helping the client work through this. If you jump to solutions and they're too fast, that's really how you trip up sometimes. So as much as you possibly can, go slow. 2 heads are better than 1. I love these koalas, but crisis work is not supposed to be done alone, period. You do it if you have to, but no matter what your level, consulting wherever and whenever possible is the best thing that you can do. Because in a crisis, your thinking can be like a little jumbled because what you're facing is a really stressful situation. So having a colleague that you can talk to, you will come up with the best treatment.
And then is just to put out there, like, if you, for some reason, we hope this is never the case, but if you are feeling really isolated and you don't have people to consult with in that moment, you can always call the crisis line. Like, that is what we're here for. I don't know if anybody on the crisis line wants to speak to it, if a provider has ever called them to consult. Has anybody had that experience?
Yeah, I think it happens pretty often that providers who are not that familiar with treating clients who feel suicidal do call for consultation. And yeah, being able to kind of go over those logistics of what a thorough assessment is. And I love that Jess highlighted that research too, that like talking about it doesn't increase the risk, which I think is yeah, a very common fear and prevents people from talking about it openly.
Yeah. Thanks, Amanda. Thanks for normalizing that. You know, you could have a PhD in suicidology, you could do all the research, but sometimes when it's just you sitting with a client, it's freaky. And I'm the clinical director here at Crisis Support. I've been on the crisis lines for many, many years. And most recently, when I had someone disclose that they were suicidal, I called my friends immediately. I don't know if she's on here or not. I think she was on here a minute ago. But I consulted, like, no problem. And I work at crisis support, so it's not like this, I shouldn't know this, but this is not something you want to hold on your own. Also, we're free. So why would you not call us? We're free and we're open 24 hours. And we're super nice.
And Stephanie is saying that ACBH Crisis Services also receives calls from providers. So yeah, multiple resources are available.
Yeah, and they are also free and they are also nice.
Yes. All right. So you start with a basic assessment. Do they have a plan? Do they have means? Are the means viable? It's important that I can think of one example. So I'm from Florida, which probably most of you know is a very flat state. And I've seen clients who talk about jumping off of bridges, and there are no like bridges in most of the state of Florida. So then I look for, do they have a car to drive to Tampa? Right. So you want to look and make sure that the means are and they're viable, and how likely is this to happen? And to think clearly about that. Okay. So
I think go Jess.
No,
just
go
keep
ahead.
going. No, you just keep going.
Please feel free to step in. Some just like things to know when you're carrying on this assessment. So provide genuine care and empathy with Cameron, share your concern, and work to build a therapeutic alliance. There is nothing worse that you're in an individual session with someone and they mention suicidality and you're asking follow-up questions and you're like, okay, so you're telling me that you're going to kill yourself today. What are your means? And it's like becomes this barrage of questions instead of that gentle kindness that we need to have with people. It should not then become this clinical assessment. It is a clinical assessment, but the trick of it is to like be warm and kind and as loving as you possibly can be. Invite them to collaborate with you on a safety plan. See if you can make a clear plan regarding access to a car. Ask their thoughts about hospitalization, give referrals to the crisis line, ask if they will put the number in their phone, offer to call them. Okay, so we're back at Cameron. Sorry. This is all the stuff you could do with Cameron. Provide referrals to grief support groups and substance abuse support. Oftentimes, I just want to plug in for SUD, like, you know, many clients who are having suicidal ideation also have comorbid substance use issues, and clinicians tend to ignore this and just focus on the suicidality, which is really important, safety first, but do not negate that this person also drinks alcohol. Offer to refer to a psychiatrist, discuss how you can advocate for them at school. This person was 21, so make sure when you're providing referrals, you could offer a TAE-specific program like ORCA, and talk about ways to get to the hospital without involving law enforcement if you collaborated and that's the plan. All right, got a little lost in the slides.
Any thoughts on this list? What's coming up for you guys as you read this? I guess my question is, does it feel collaborative?
Yeah.
Yes, thank you. I think people can disagree. But I think we just wanted to make sure that as we're saying all of this, we want to be really clearly communicating that all of these steps are happening with the consent of the client. So this isn't us saying, I'm going to call your school for you. I'm going to take the keys to your car. Like, this is starting off with, like, what are some things that you think could be helpful? Developing a trusting relationship so the person can be as honest as possible. But then these are all things that you are offering, right? So we're offering these to see if they could be potentially useful for this person. Sometimes, you know, our role is when we're working with someone who is experiencing suicidality. I know you guys all know this. People get very tunnel vision. And so it can be helpful for the provider to think kind of outside the problem a little bit, slow it down. It said in the case presentation that one of his big stressors is failing school. And if you were just like, well, what if we address that stressor? You know, maybe that can step back the desire to die a little bit. And in my experience of working with people who are suicidal, just like a really small care coordination step can be really useful. And again, people forget about, you know, you can just like take a medical leave. You could take a sick day. People forget those things. So it's an offering that we do in collaboration with the client. And then again, oh, Stephanie, yes, hello.
I just wanted to say what I like the most about that list is that looking at risk, legal risk, and liability is not on there, because a lot of times we receive those calls first. Like, what am I, you know, legally required to do? And what if the family sues me? What if this person commits suicide and the family sues me? And there's so much to consider before you get to being in court and being sued. It's very rare. And no, you don't want to lose the client, but there's so much work to do before you start thinking about someone getting a lawyer and blaming you if the person eventually kills themselves.
You kind of lose the person's humanity when you do that. And yeah, it's really important to be human and kind and treat that person in their humanity. And I think the liability and legal stuff really gets in the way of that. It's a really important point.
Yeah, I appreciate that too. And I wanted to say, in John Jordan's Grief After Suicide book, he addresses that. So like, he has a chapter on provider loss and what comes up for providers after they've lost a client. And he talks a lot about like clinicians who have a caring relationship with the client are just much less likely to have legal repercussion. And particularly if the family or their social system believes that the clinician cared for the client on a personal level, like that's huge. And I think, yeah, we do really forget about that, and we do really worry about risk and liability, which is why Jess and I started this training to say, like, you know, our actual legal guidelines are quite narrow. All right, Jess.
All right. Golden rule, document everything closely. Make sure that you include the ideation, the intent, and the plan. If you want, and this is a liability thing, if you want to be covered in your liability, this is all you really need to do. This is what they're looking for. Andrea, cultural considerations.
Thank you, Jessica. So although white identified, I have so many grammatical errors on this. White identified individuals compose the largest percentage of deaths by suicide. The suicide rate of youth of color are also high and rising. Suicide is the third leading cause of death among Black men aged 15 to 24. Black children between the ages of 11 and 15 have the highest increases in suicidality. Do people know this? Is this new information? Does anybody have anything they want to add to this? Or any thoughts of any providers who want to share what they're seeing or what they know? Is it surprising, or is it what people already know?
I don't think I knew that suicide is the third leading cause of death among young Black men. That is horrifying.
Yeah. Yeah, and we can have a whole other training on this, but you know, we really think about suicide prevention as violence prevention. And if we think that, I think the second leading cause of death among Black men is homicide, the factors that cause someone to die by suicide and the factors that lead someone to die by homicide or end someone else's life are very similar. And I think that I wish we talked more about suicide and homicide as being really two sides of the same coin. This is all violence prevention. Any other thoughts? I'm going to guess that this is probably known to many people who work in Alameda County. This has been, I think, a conversation for a while. We also know that American Indians and Alaska Natives tend to suffer from feelings of alienation and of less access to health services. This contributes to alcoholism and opioid addiction, as well as suicide and suicidal self-harm. We also know that cultural factors mean American Indians and Alaska Natives are less likely to recognize health issues and seek health services. In turn, the majority of health services are not designed for this minority group or for any minority group. And so we want to really highlight that a lot of what we know about suicide research and suicide best practices and interventions is normed on white people. Like, that is just a reality. If you look at who has developed the leading theories when it comes to suicide prevention, it is white men. When we think about how we define suicide is how white men die by suicide, and that's through violent acts. And so it obscures the way in which women and people of color die by suicide, which is often very different. It obscures what risk factors look like among women and people of color, and it obscures what the warning signs might be. So we want to really name that, right?
I might add, I was just going to add just a plug for 988. There are special lines dedicated to people who are American Indians. And one of those lines is coming to California. So please look out for that. And those lines are staffed by people who are within the tribes within California. And you can talk to someone who knows the sort of cultural norms with this. So we're really excited to be having that come on. So just a little
Great plug, Jess. Thank you.
Thanks.
But yeah, we want to be really clear that when we're talking about evidence-based practices, these evidence-based practices are not norms on people of color. And so we want to be really critical about the interventions that we're using, particularly if we're working among communities of color. So we also know that youth of color are less likely to receive preventative mental health care and are more often referred to mental health care through crisis services. There's like a study that was done on Latinx young women who have the highest rate of like reported suicide. So they most often experience suicide among any kind of group. But young Latinx women most often receive referrals to therapy after being hospitalized. So white identified youth who come from means, they might have people they can go to say, you know, I'm not feeling so good. Talk to a teacher, talk to a trusted adult, and get referred that way. But for youth of color, it's much more often following a hospitalization. So we're not doing the best that we can to recognize what are the warning signs for youth of color, or providing enough resources out there so youth of color don't have to go through hospitals to get referrals for mental health care. So there's a lot of, you know, systemic barriers in place for communities of color to receive services. Anybody want to drop an idea as to what some of those barriers might be? Or maybe you know from your work? Cultural stigma, yeah. Oh, 2 of you guys had cultural stigma. Forced medications. So we know that people of color are more often prescribed medications, and those medications that they're prescribed tend to be strong medications. I don't know the actual word for that. Strong, big medications. Finding providers from your community is difficult. Yeah, so finding a provider who looks like you, reflects your culture, is much harder when you come from an underserved population. Fear of support system, especially medical. Yeah, thanks, Ashley. Language barriers, definitely. Yeah, I oversee a clinical program and we don't offer services in any language besides English. So we are an actual example of that barrier. Fear of punitive interventions and police involvement, definitely. It's very real. Yeah, great job, guys. Great job doing this slide for us. And so we would imagine that Cameron is a young Black man. At intake, he tells you he would never go to the hospital if suicidal due to the risk of police involvement. He tells you he has been arrested in the past and being hospitalized is too much like jail, and he would rather die. As a clinician, you understand that Cameron is not incorrect. How do we adapt our practices to support our clients from diverse backgrounds? Okay, that was the answer. But what do you guys think? Imagine this is your client, someone's in front of you and they say, going to the hospital is too much like jail, I'd rather just die. What are some things what some thoughts you might have? What are some approaches you might have? Suggest a peer respite. Plan of ways they can stay safe without going to the hospital. Acknowledging and validating their experience. Yeah, validate his feelings. Other options, validate his experience. A lot of validation from this group. Validate the fear. Offer voluntary outpatient psychiatric care and peer groups. And then what's coming up for you guys as you think about working with a client like this? Like, what's on your mind? Yeah, showing understanding of the harm the mental health system and hospitals can do as well. But what's coming up for you guys? Would this feel like a hard situation? Would it be similar to ones you've had in the past?
I think it feels difficult for me, and I can't quite put words to it at the moment. But I
Yeah,
know there is this feeling of discomfort. um, and part of it is like, yeah, that's valid. And also, what if the hospital is the best support in this situation, and thinking about how to have that conversation with this,
yeah,
if it is, there's a lot of things we can do before that, but like the hospital is a valid support system too, if needed, if that is
yeah.
what's best for this case. So I think that's feeling that's coming up for me.
Right, right, right. It's not so simple. Stephanie says it's a purpose in life. I want to help everyone, but especially those who come from the community I come from. Thank you, Stephanie. Yeah, I think this is, this slide came from experiences that I had. I work with a program here in Alameda County for young people who had identified mental health disorders. Many of them are young Black men. And we were often sitting with the fact that they would benefit, either they had nowhere else to go besides the hospital. Their symptoms were debilitating. I had a client who had just made a suicide attempt, and I want them to go somewhere where they're going to get help. And the reality is they had often been to those hospitals and had terrible experiences. And so I kind of was just always kind of angry, like mad. That's how I felt about it. Just angry. And this is, even in Oakland, which is not a perfect city by any means, but I feel like it's a city where people are aware of racism as a construct. And even in Alameda County, I never felt comfortable calling the police on any of my clients. Or even having them go to one of our hospital systems, because you just don't know what's going to happen. This always seemed to somehow involve law enforcement when you didn't want them to. So some ideas that we had, you all had mentioned, but just want to name some of these. And we want to be real. There's no perfect answers. When Jess and I have the answers, we would charge you like $1 million for this training. But this training is free because we don't have any answers, but we have some ideas. So I am always very clear when I meet a client, what would get me to a point where I'm going to hospitalize somebody. So I start there. I ask them, have you ever thought about suicidality? And before you even tell me, I'm going to tell you what I do when people are suicidal. And I say, I really try to avoid hospitalization. I say this to 11-year-olds. Like, I'm very clear with everybody. I want to do what I can to keep you safe in the least restrictive environment possible. So if you come and you tell me you're suicidal, I'm not going to jump on the phone and call 911, right? We're going to work together on this. But here are some of the things that would happen that would make me think that you would benefit from being in a hospital, and I would always tell you. So I'm always very clear and upfront. And then I talk about the idea of voluntary hospitalization, which I've had clients admit themselves. It's been a much different process. It's gone much better for them. Definitely talk about crisis stabilization centers like Sausal Creek or Sally's Place, so they don't have to go to a hospital. Many of our clients had never heard of these, so they didn't even know they were options. Sometimes when I was doing a lot of community work, we would drive by and we would visit. I'd be like, look, that's Sausal Creek. It's a tiny little office. You can walk right in if you need to, or bring them to Woodrow. They can see where it's at. It's in a lovely community. And then I would also, if I had a client like Cameron who was saying that I'd rather die than go to the hospital, I would find a way to bring that to his support circle and let everybody know he really does not want to go to the hospital. Like, this is his very strong ask, that if something happens, we support him and help him stay safe without being hospitalized. And then try to connect him with a provider of color who comes from his community and refer to peers or a peer-based or affiliated program. Any thoughts on this or anything that we have missed? Anything that you guys might add or that you have done in the past that has been really helpful that you want to share with us?
I will add that I think it's very important for us to teach our consumers how to advocate for themselves as well.
Yeah.
That there's a lot of education that needs to happen of, low barrier voluntary programs but also what their rights are in terms of what can happen during a hospitalization. Because there are some people that their behavior is so dangerous at that moment, or they're so high risk where they need some kind of stabilization somewhere in a facility, unlocked or locked. But, teaching about, what your rights are, what you can ask for, what you can refuse, I think that is helpful too. So it lends to people making more informed decisions about their own care.
Yeah.
If family members are around, helping them become better advocates too, like referring them to FERC.
Yeah.
There have been times where, we've asked people, we've had this scenario where the person said, if I go back to the hospital when I get out, I'm going to kill myself.
Yeah.
Where we said, well, who can come and be with you? And sometimes it's a neighbor, that understands, has gone through it, and they say, I will sit with this person for 24 hours if I have to, those kind of things. So really looking at the natural supports, advocacy, psychoeducation about, what this is supposed to do, because I'm a person, I have written probably thousands of 5150s, and I'm in agreement. Hospitalizations, forced hospitalizations are the worst for people. Even if they get better, it's that initial, taking away someone's rights, the initial assessment and registration, and that whole process of kind of feeling like you're incarcerated, that people experience. And watching other people at the worst time of their life can be traumatic too. So the more people we can divert from hospitalizations, the better our whole system will be, and the healthier our communities will be, for sure.
Yeah, thank you so much for that, Stephanie. Yeah, we are by no means trying to say that people in our hospital systems aren't doing the absolute best they can. We have a lot of respect for them, but that is a rough situation. It's a rough setup. I want to put in an idea that if you are a provider, educate yourself on these systems that are out there, and that includes going there. I don't know like how far you could get into it, but even just like knowing where John George is, knowing where Herrick is, walking by, like seeing how it is in the landscape. I think a lot of providers in Alameda County don't realize that John George is like far up on a hill, like I don't even think a bus goes up there. Like it is really separate. It is far. It's surrounded by turkeys. It's very weird, honestly. And so I think like even just knowing where these places are and knowing how hard they are for anybody to access is important to know. So I just want to put that idea in there too. Anything you want to add, Jess? We'll talk more about crisis systems and stuff too.
Nothing more to add, really.
Yeah, and Hillary said, I think hospital pairs with other agencies, places, et cetera, within the system. You have great workers in a broken system. And she says she talks to clients and support people a lot, and just validating this. Thank you, Hillary. Okay, the crisis continuum and resources in Alameda County. We're going to educate you a little bit. If you perhaps know more than us, like maybe you work for the county and you want to drop in any information, please feel free. So last time we did this training, we said the cavalry is not coming, which is what Jessica said. Like, we don't want people to think that there is, you're going to press a button and angels will appear and support your client to some beautiful, magical place. But change is on the way. So Jess is going to talk a little bit about what's out there.
Okay. Alameda County has a patchwork of services that provide support to people experiencing suicidal crisis. What we're going to go over, and I'm sorry if this is kind of review for some folks, we're going to go from the lowest level of care to the highest. And these also can be found on our crisis referral website as well, if you want more comprehensive list. So the lowest level of care is CSS, our local crisis line, and 988. Not only is like sort of the lowest level of care, but it is liminal care. So people call us in crisis and they're imminently suicidal. So actually they're really at high risk to low risk. So even despite the fact that we are like the lowest level of care, you're going to get a counselor on the phone, or via text. We deal with folks whose needs span this crisis continuum. So this is a good resource to call, whether in consultation or if somebody is, needing emotional support to prevent that suicidal crisis or is at imminent risk. 211 as well for some of those, like if the person needs housing resources. And then for Medi-Cal patients, access at Alameda County is also a really great resource to call. And if the patient is Medi-Cal, they will connect you to services. All right, so you have the crisis line, right, which is really a very low level of service. And sort of in the crisis continuum, there are CSUs, basically. And these are for folks who really are, at risk. Either they're having suicidal thoughts, or maybe they've stopped taking their medicines pretty recently, and they're on their way to a manic episode. This is for somebody who, and this will probably be the most common level of care if we consider hospitalization at the very top, and hospitalization should be used as infrequently as possible. Lower levels of inpatient care, Amber House. So what they do is they offer short-term 24-hour assessment and triage. They have a nurse and a social worker on every shift, and on-call psychiatry is available 24/7. This is for adults, and it is voluntary. That's the important piece about this, is that this service is voluntary. You're not sending someone to a locked unit where they can't leave. So when you send someone to Amber House, please just be aware that if someone is at imminent risk and they're going to do something to end their lives and they need to be in a safe place, this might not be the right place. However, this is the right place up until that point. And this tells you what they do. All right, next slide. So Amber Place, how I remember it in my head, and I don't know if this will make sense to you, Amber, I think of assessment, and I think that Amber House, I think Amber House is run by clinicians, their psychiatric staff, where Sally's Place is run as a peer respite. Again, same type of placement. This is for somebody who does not need to be in a locked unit. This is for somebody who's having symptoms and you're trying to offer some preventative care and stabilization. And it's a 24/7 short-term program. And I love that it is peer run. Like, the peer movement involvement in crisis has grown, and I love it, because sharing lived experience with someone, if you are a peer, is really powerful. And that's something as clinicians we don't get a chance to do. So it's pretty important. We have J. Mahler Recovery Center, which is also a CSU, again, like clinically run. If you refer clients to them, they have to have a primary mental health diagnosis, but can also have a dual diagnosis with substance use. It's again for adults. You have to be Medi-Cal or Medi-Cal eligible. And it tends to be a longer stay. But again, great place for somebody who, again, does not need to be on a locked unit. It's certainly clinical if you've ever been there, but it's not locked.
We only have 4 minutes left, so we're going to go real quick.
Stephanie, you said if you want to talk a little bit about J. Muller. I saw your
Yeah, I'll just go real quick. You said J. Mahler is a CSU. It's actually a CRT. So CSU, you can stay for 23 hours, 59 minutes. A CRT, you can stay for up to 2 weeks. So it's a continuation of crisis stabilization. One is Crisis Stabilization Unit, CSU. The other one is a CRT.
Thank you.
Yep.
Yeah. It's this is the other piece. Like we like throw around these, CSU, MRT, it's just a lot of, yeah. Okay. So mobile crisis teams, and this is also like, these folks are sort of liminal. They interact through all levels of crisis, and are becoming, prior to like this year, we've had mobile crisis teams for a while in Alameda County, but their hours are often scattered, and there are a lot of them. So trying sometimes to find a crisis team that's the appropriate one for you, and finding the hours that are open can be a challenge, but all of that is soon to change. So who might be appropriate for a mobile crisis response? So it's funny, as Grace and I have been thinking about this a lot, one of the things to remember, if you're going to call mobile crisis, make sure it is somebody who's really not at imminent risk, somebody who's already taken steps to end their life. And how you can think about that, how we found that the easy ways to think about that, it's going to take 45 minutes to an hour for a mobile crisis team to arrive. So if you have a client in front of you and they cannot wait 45 minutes to an hour, maybe mobile crisis isn't the right referral for them. It's also not the right referral if somebody's already taken or done something to end their lives. But mobile crisis teams are wonderful because they can help really prevent and connect people to the appropriate referrals. So, and they're regardless of insurance status, they're available to all ages. They do emergency crisis assessments, and they also make referrals to get people connected to care. Yeah. 988, the 988 system talks about someone to call, someone to see you, and then somewhere to go. And I think we're really in this sort of like this, as we work on all three of those mobile crises, we've worked on 988, we now have 988. So the next sort of goal is having someone to see a person who's in crisis. And I think that we're going to see an expansion of mobile crisis units. They will be 24 hours coming up soon, and it's really exciting. So
I do think we're out of time. So just want to say, just last thing, then we have hospitals. So that's the highest level of care. So there's so many things to do before we send someone to the hospital. Okay. We have the eval in the chat. I'm so sorry we didn't have time for questions. Hopefully you had a chance to drop in questions as they came up. If anything ever comes up, you can reach out to us. You know how to find us. We're here at Crisis Support. We'll definitely send out the slides. I think Ben's going to post them wherever he posts things. But yeah, thank you so much for being in attendance, and we will see you all again, I'm so sure, out in the world.